Welcome to the Liver Lounge, your go-to podcast for the latest updates in hepatology, featuring discussions with the world's leading experts. In today's podcast, we are delighted to have Dr. Daniel Huang, a transplant hepatologist at the National University Hospital in Singapore. His expertise lies in the early detection and prevention of hepatocellular carcinoma in non-alcoholic fatty liver disease and viral hepatitis. With an impressive track record, including numerous publications in high-impact journals like Cell Metabolism, Gastroenterology, and Lancet Oncology, Dr. Huang is a leading expert in this field. Let's welcome Dr. Daniel Huang.
Hey, hi, Dr. Daniel. So thanks so much for coming today. So can you tell us about, you work a lot on NAFLD-HCC and other related HCC studies. I was just wondering, can you share with us more about why NAFLD-HCC is very important in the context of the 21st century?
Thank you, Dr. Ng. Liver cancer is the third commonest cause of cancer death, and we now know that NAFLD-HCC is the fastest growing cause of liver cancer. Not only is it the fastest growing cause of liver cancer, now NAFLD-HCC is actually the leading cause of HCC among waitlisted candidates in the United States. So clearly, the tide has shifted in terms of the cause of liver cancer from hepatitis B and hepatitis C in the past, and it has now swung towards NAFLD as one of the leading causes of HCC. With more and more people increasing BMI, increasing prevalence of obesity and diabetes, we anticipate that the burden of NAFLD-HCC is going to continue to rise very sharply in the next decade.
Okay, so you've done a lot of studies in NAFLD-HCC. Is there any screening guidelines that you think? There currently exists no clear-cut screening guidelines on how to do for NAFLD-HCC. What do you think would be the best and most cost-effective way for screening, and also who do we screen?
Yeah, that's a great point. Certainly in patients who have cirrhosis, stage 4 fibrosis, and NASH, these patients should definitely undergo surveillance for HCC, especially if they are candidates for liver transplantation. However, as you mentioned, there isn't a consensus on how patients without cirrhosis, patients with NASH but without cirrhosis, whether these patients should be screened. And this is, I think, an area that is still undergoing research, and we are debating about this. For example, EASL recommends that patients with NASH and stage 3 fibrosis, in these patients, screening can be individualized. Whereas the recently released AASLD guidelines for HCC have just recommended that screening should not take place in patients without cirrhosis. So certainly, I think this is an area that continues to evolve. I think from my personal standpoint, I agree that we may not be able to recommend surveillance for all patients with stage 3 fibrosis, but I think in those patients with stage 3 fibrosis and NASH with multiple risk factors, such as those with diabetes, those with a family history of HCC, I think these can be considered for screening, but we need better strategies on how we can risk stratify such patients.
But then, would you then think that we all know that screening for NAFLD-HCC is important, but how about the absolute number for NAFLD-HCC patients? Are they very high percentage? Is it a very high percentage in the total NAFLD?
Well, I think one of the issues that is faced by clinicians all over the world is that I think the denominator or the people at risk of NASH and NASH HCC is very big, but the numerator, those who actually go on to develop HCC, is small. The problem with this is we are currently, it's like finding a needle in a haystack. we have so many patients at risk. We don't know which of these are going to progress to HCC. So certainly, I think taking an approach of screening everybody with NASH without cirrhosis for HCC is not going to be cost effective. So I think currently we are working on strategies how we might be able to identify such patients who do not have cirrhosis but maybe have multiple risk factors, and see how we can streamline these patients into a workflow that still remains cost effective.
But then how would you screen these patients? The
Oh,
current
you mean
yeah,
from
like screening
if one were to show up in my clinic?
yeah, like what would be a best way to screen for NAFLD-HCC?
Oh, I see. Do you mean in terms of like the modality of
Screening
like
better.
what's yeah? Oh, yeah, that's a great question. I think work from our group and also other groups have shown that the presence of NAFLD as well as obesity actually reduces uh, the quality of surveillance imaging by ultrasound substantially in people with NASH. And so, in fact, NASH and obesity are independent predictors that of poor visualization quality on the ultrasound. I think one potential strategy to deal with these issues is to try to incorporate using the LIRADS visualization score uh, in our ultrasound reports, so that when clinicians see that the LIRADS visualization score on the ultrasound is poor, then they can think of alternative means to survey such patients. I think there are several modalities that are potentially useful in this situation. The standard is ultrasound, but when visualization is poor on ultrasound, then cross-sectional imaging can play a role. These patients can be considered for complete MRI scans, CT scans. The trouble with these modalities is that complete MRI scans are costly. They take a long time, about 30 minutes or 40 minutes per scan, and access to these are poor. CT is much faster and it's cheaper, but it comes with radiation and contrast risk. So I think many groups, including ours, are now thinking of alternative modalities on how we can screen such patients. One potential modality is using abbreviated MRI, which uses only one third or less of the sequences of a complete MRI, and the scanner times can be as low as less than 10 minutes. And in one of our studies, we showed that the rate of visualization failure in abbreviated MRI was substantially lower than ultrasound in the setting of NASH cirrhosis. However, as I mentioned earlier, access to abbreviated MRI protocols or even MRI in general is somewhat limited. But I think these are newer modalities that may become more common in the future.
Okay. So in that case, I guess screening for NAFLD-HCC remains very challenging. Is this challenge, however, faced across all the other etiologies of liver cirrhosis, or more specific for NAFLD?
Yeah, good question. I think in general, the sensitivity of ultrasound for HCC of any size is in the range of 60 to 70%. However, regardless of etiology, there was a previous meta-analysis that showed that the sensitivity of ultrasound for early HCC was 50% or lower. And hence, I think this is a challenge that is not unique to NAFLD-HCC, but certainly the presence of NAFLD and the presence of obesity exacerbates the problem. Certainly, these patients are at, I think, higher risk of having missed lesions compared to other etiologies of liver disease.
Okay. So in a way that's a bit is a bit more specific to NAFLD because of the background comorbidities that usually persist with patients with NAFLD. Okay.
Yes.
How about the management of NAFLD-HCC? Is it different also compared to other etiologies?
I think the general principles are the same. A few issues that I think patients with NAFLD-HCC face that number one, I think these patients have many comorbidities. They tend to have diabetes, they tend to have ischemic heart disease, they tend to be obese. And so I think that the HCC itself may be just one of multiple competing medical issues that uh that the and challenges faced by the patient. So, for example, the same patient in NAFLD-HCC may have type 2 diabetes, they may have chronic kidney disease, they may be obese, they may be ischemic heart disease, and I think these multiple comorbidities, they they add together and increase complexity of how such patients may be managed. So, for example, in a patient with morbid obesity, ischemic heart disease, such patients may not be great candidates for liver transplantation. So while in itself, I think the etiology NAFLD-HCC, if in a head-to-head comparison with similar HCCs from other etiologies, they may not have that much difference in terms of how they're managed. But when you consider the whole patient together with all comorbidities, then it becomes a lot more challenging for the clinician to manage.
Okay, so now we're transitioning towards like NAFLD, steatotic liver disease, as a alternative definition to NAFLD, and I think it's been recently accepted by EASL and also SSLV and also many of the other major hepatology societies. How would this affect then in HCC screening?
Well, I think the moving forward, the old nomenclature of NAFLD was clearly suboptimal. I personally feel that the addition of criteria, say for alcohol consumption, to the definition, it helps to provide a clearer picture of the whether the driver is metabolic in nature, whether it's alcohol in nature, or whether it's a combination. I feel that it is a step forward. But in terms of the impact on screening and surveillance, I think more work needs to be done. These have not been clearly defined in terms of research studies, but I do not think personally that the name change will have a major impact on the utility of, or rather the utilization of HCC surveillance.
Okay. So I think to sum it all up, I think mentioned that NAFLD-HCC remains a growing cause of concern, and with the change in the nomenclature, I guess it might also improve the detection and understanding in the way that more patients are captured under this definition, and therefore more people can go through proper screening procedures in that way. Will you agree?
Yeah, I think the name change, right now we are still dealing with us clinicians. Like many of my colleagues have just, in fact, one of my colleagues was from gastroenterology was asking me earlier today about what's the name change, what's the new name, what's the new definition. So I think we're still at the phase where the clinicians themselves, the care providers, we are still personally kind of in a in a transition phase where we are coming to terms with the change in name. And then after that, we will then have to educate our patients. So I think this process will take time. It's not going to be like an immediate switch. Will take time to convey this to our patients. And I think long term, I'm not sure about its implications on patient understanding and impact. We also need to consider cultural sensitivity. Each culture is different in terms of dealing with names such as fatty or steatotic, and in certain cultures, this name change may not even have any impact because some certain ethnicities or race groups will be speaking in their own uh, uh, ethnic language. So whatever that happens in the English speaking world may not apply to them directly. So I think there are many moving parts, and we as a community, we certainly all have to work together to improve disease awareness and understanding among our patients and also among clinicians.
Okay, thank you so much, Dr. Daniel, for your time.
We have come to the end of the episode. Thank you for joining us and stay tuned for more captivating discussions.